Greetings again, everybody. I know it's been a long time since I've put a video up, about a month and a half. I apologize for that. I just took a new assignment out in Michigan, so it's been about a 500-mile move for me, and it's been quite busy. So here we're going to talk about congenital uterine anomalies. You'll also hear me refer to this as anomalies of the Müllerian ducts, and that is indeed what we are going to talk about here. So this is a vignette. You don't have to think too much into this because we pretty much put everything here. So a 26-year-old G30210 woman presents to your clinic after 3 successive preterm labors. Note that in her obstetric history here, you see that she's had 3 pregnancies. None of them have gone to term. 2 have been preterm deliveries. 1 has been a spontaneous abortion, meaning before 20 weeks. And she has 0 children living, of course. Her preterm labors / spontaneous abortions occurred at 18, 22, and 20 weeks gestation. She and her husband wish to start a family and would like to understand why they continue to lose pregnancies. General physical exam is unremarkable and the patient is otherwise in good health with no significant past medical history or past surgical history. Pelvic examination reveals a normal vaginal vault and cervix. Cytogenetic analysis are performed on both the patient and her husband and reveal a normal karyotype with no genetic translocations. Prolactin, TSH, and hemoglobin A1C are within normal limits. Lupus anticoagulant is negative. Sonography is performed and reveals an apparent duplication of the uterus. MRI reveals a 2-centimeter fundal cleft, and there is a bicornuate distance of 5 centimeters. There is only 1 apparent cervix. So this is a diagnosis here of bicornuate uterus, which is the most common Müllerian duct abnormality or the most common congenital uterine abnormality. All right, so we're going to talk about these in greater detail. But the most common way for these congenital uterine abnormalities or anomalies to show up is preterm labor because the uterus is not big enough, it's not normal in shape, it's not big enough to support a pregnancy. Now, a lot of these women do go on to have normal labor and delivery in some cases, but because of the size and shape of their uterus, they're more likely to have preterm labor, and that's indeed what we see in this patient. Now note that we did a nice, good workup, infertility workup for this patient. I guess you wouldn't really call this an infertility workup so much because we know that they are fertile, they are having pregnancies, but we do a workup to check to see if there are any explanations behind why she's continuing to have miscarriages, essentially. And so the American Society for Reproductive Medicine recommends cytogenetic analysis, looking for chromosomal anomalies, namely looking for translocations, balanced translocations, and then also checking various hormones, including prolactin and TSH, checking for hemoglobin A1C, and then checking lupus anticoagulant. Okay? So after we do all that, then we start thinking about possible anatomic issues, and approximately I think it's around 5 or 6% of women will have some kind of anatomic abnormality of their uterus, so this is not terribly uncommon. So we're going to briefly talk about the embryology of the paramesonephric ducts, which is the Müllerian ducts. I put it in parentheses here, para, because there's mesonephric ducts, which develop in men. That's the Wolffian ducts. We'll talk about those, what those are, how they develop. And then we're going to talk about these various anomalies of the uterus. So there's Müllerian, Hypoplasia, and Agenesis. We also know this as MRKH syndrome, which we talked about in another section because it does have implications for the cervix and vagina. We will talk about Unicornuate Uterus, Didelphys Uterus, Bicornuate Uterus, Septate Uterus, and Arcuate Uterus. Okay, so this is a stray cat I found since I moved out here. She's actually underneath my feet right now, biting at my ankles. But remember, with stray cats, well, any cat really, when you're dealing with pregnant women, as we're talking about here, what can happen? Congenital toxoplasmosis, chorioretinitis, seizures, hepatosplenomegaly, thrombocytopenia, intrauterine growth retardation, fetal hydrops, microcephaly, intracranial calcifications. So cats can be dangerous, even cute little kittens like this. So I wasn't planning on taking a cat in. She found me, but actually she found a friend of mine, and I volunteered to take it in. Sometimes I think my heart is bigger than my brain. Lots of work. Okay, so the embryology of the paramesonephric ducts. First of all, what are they? They are paired structures of mesodermal origin which give rise to the reproductive organs. Some of the reproductive organs. So obviously you have your testes and ovaries. Those do not come from the paramesonephric or mesonephric ducts. And then also there are various other structures like the distal vagina, the penis. Those also do not come from these ducts. These ducts are, what they do give rise to is, in males, you have the Wolffian ducts or mesonephric ducts, which give rise to the epididymis, vas deferens, seminal vesicles. I should say vesicles, there's two of them. And then in females, the paramesonephric ducts, which we are concerned about here, they give rise to the fallopian tubes, the uterus, the cervix, which are not listed here, and then the proximal third of the vagina. So all developing fetuses will have both paramesonephric or Müllerian ducts and mesonephric or Wolffian ducts. And around, I think it's around like 8 weeks, once you start getting sex differentiation, one of these ducts are going to involute. And in males, it'll be the Müllerian duct that involutes, and in females, it'll be the Wolffian duct that involutes. And males produce a hormone. It's called anti-Müllerian hormone. It's got some other names too, but anti-Müllerian hormone. And that is ultimately activated by the SRY gene, which creates testis determining factor. That also activates SOX9, which directly then alters the expression of AMH. So males produce AMH, and that ultimately will cause the Müllerian ducts to involute and the Wolffian ducts to develop. In the females, they don't have AMH. Their paramesonephric Müllerian ducts will develop and the mesonephric ducts will involute. Now, this doesn't happen all the time. It's possible for females to have a persistent Wolffian duct where the Wolffian duct doesn't totally involute. Remember what that is? If you go back to our section on the vagina, that is the Gartner's duct cyst, which can form on the lateral wall of the vagina. There is such a thing as persistent Müllerian duct in males. We see typically what happens is they have a mutation of the AMH gene or the AMH receptor gene. It's rare, but it is a known entity. Okay, so that's our mesonephric and paramesonephric ducts. What we're talking about here is abnormalities of the paramesonephric ducts or the Müllerian ducts. Okay, so these are the Müllerian and Wolffian ducts. This is in a undifferentiated fetus, around 7-8 weeks since last menstrual period. So that's usually, or last missed period. So that's typically how we date them in medicine. But this is around like 9-10 weeks of gestation. So that's typically when we see sex differentiation happen. So note that these ducts get their name from the fact that they are close to the kidneys. And in fact, when you have abnormalities of these ducts, it's not uncommon to also have renal abnormalities. So keep that in mind. So in males, you have the Wolffian duct that develops. It forms these structures basically that connect the testes to the prostate and to the urethra. So that's going to be the epididymis, vas deferens, seminal vesicles. In females, they form basically everything from the ovaries to the vagina. So we have the fallopian tubes, the uterus down here, and then the cervix and the upper part of the vagina. The distal vagina is formed from the sinovaginal bulbs. Okay, and ultimately these should come together, otherwise you get that septum, if you remember back to our talk on the vagina. So some general principles of uterine anomalies. The prevalence is about 6.7% in the general population, and the most common presentation or presenting symptom for uterine anomalies is recurrent preterm delivery, as we saw in this patient. Now, there are some other ways that this can present if they're more severe anomalies, and we're going to talk about those. They can present as early as adolescence. You don't even need to get pregnant. You can show up with issues with your period or with other problems like that. Though the Müllerian ductal system gives rise to the entire upper reproductive tracts, only the more severe anomalies will have an abnormal external appearance. Again, we'll talk about that in a little bit. The best initial test and diagnosis is pelvic sonography, then followed by pelvic MRI. You might think that the best test to do, the most accurate test, would be a hysterosalpingogram. It's not. And there are various reasons for that. We don't see as much as we see in the MRI. However, a hysterosalpingogram is generally a really good way to look at the female reproductive tract and anatomy. And I have pictures of hysterosalpingograms I'm going to show you just to illustrate the shape of these abnormal uteri. But I want you to know that hysterosalpingogram is not traditionally done in diagnostic workup for these anomalies. Okay, so we're going to talk about these, and these historically have been divided up into classes of Müllerian ductal abnormalities. We don't use that anymore. We call them what they are. So we're going to talk about Müllerian agenesis or hypoplasia, which is a failure of both ducts to form. Remember that these are paired ducts, so they not only have to form, but they have to fuse, and then there's a septum left in between, and that septum has to dissolve. Okay, so we have 3 steps here: formation of the ducts, fusion of the ducts, and then dissolution of the septum. Okay, and that's going to be important that you know those 3 steps, because it will make these disorders make more sense. And really, when we go in this order, we're talking about severity. So this Müllerian agenesis or hypoplasia will have the most severe impact on the woman. She will not be fertile. Well, she'll be fertile, but she will not be able to carry pregnancies. So that will be the most severe. That's a failure of both ducts to form, unicornuate uterus, failure of one duct to form. The uterus didelphys and the bicornuate uterus is failures of fusion. Septate uterus and arcuate uterus is a failure of the septum to dissolve. And then we're not going to talk about the DES or T-shaped uterus. That is due to a teratogenic effect of DES. We don't see this that much anymore. Women who had problems with miscarriages back from 1940 to 1970 roughly, they would take diethylstilbestrol, which was supposedly supposed to help with miscarriages, help women carry their children to term. What we found was that little girls who were born to women who took DES would have problems with their reproductive anatomy. Now the thing is that women who were born in 1970, now they're approximately 46 years old, and they're sort of past their childbearing years. So it would be unusual to see a woman with a DES uterus affecting their pregnancy, but I suppose 46 you can still carry a child, so it's possible, but not so common anymore. So these are the congenital Müllerian anomalies, congenital anomalies of the uterus. Congenital anomalies of the uterus really is not necessarily the best way to put it, because certainly in uterine hypoplasia you're going to have hypoplasia also of the fallopian tubes and of the cervix and upper vagina as well. But mostly we're concerned here about the uterus. That's going to be where most of our implications come from. So Müllerian hypoplasia and agenesis, this is known as Mayer-Rokitansky-Kuster-Hauser syndrome. We talked about this in previous sections. This can be complete, in which we have complete Müllerian agenesis, so you have no uterus, no fallopian tubes, no cervix, no upper vagina. However, in most cases, it's only partial, so you'll have hypoplasia. You'll have some rudimentary uterus and fallopian tubes and vagina, but it's going to be primarily hypoplastic. So the most common presentation for MRKH syndrome or Müllerian hypoplasia / agenesis is primary amenorrhea. Why is that? They have no uterus. If they have no uterus, they have no endometrium. If they have no endometrium, it doesn't matter that they're hormonally normal, they're not going to have menstruation. You need endometrium to have menstruation. So they will have primary amenorrhea. They will never get their period. However, they'll go through the rest of puberty totally normal. They have ovaries, they're fertile, they just can't carry pregnancies. So they're hormonally normal, they'll have thelarchy, they'll have adrenarchy, but they won't have menarche. So these women, if they do want to have their own biological children, they certainly can, but they'll need the use of a surrogate. Sonography is a great initial test for diagnosis. You'll look for the uterus, you won't find one. You won't find fallopian tubes, but you will see ovaries. MRI is more accurate, of course, you're going to see more. On diagnosis, once you make the diagnosis of MRKH syndrome, you should get intravenous pyelography because these girls tend to have renal anomalies. You should also get an echocardiogram. Why? Because approximately 10% will have cardiac anomalies as well. Okay, this is the unicornuate uterus. So what is a unicornuate uterus? This is a unilateral failure of a Müllerian duct, resulting in a half uterus. So one Müllerian duct forms totally normally, the other Müllerian duct either doesn't form at all or it partially forms. And when it partially forms, it doesn't communicate with the vagina or with the other half of the Müllerian duct, then what you get is what's called a rudimentary horn. And this can be a huge problem. Okay, it doesn't sound like a problem, but it really can be, and we'll talk about that in a couple minutes. So what you have is one communicating Müllerian duct, which has formed a uterus and a fallopian tube going up to the ovary here, and it forms a half of a cervix, which we can't really tell half a cervix from a regular cervix, so you do have a cervix. So looking from the outside, this looks totally normal. You have vagina, you have a cervix, you have what you think to be a uterus, and it is a uterus, but it's only half of a uterus. On this side, you have nothing. Okay, there's no communication between the vagina and the rudimentary horn. You likely do have a rudimentary horn. I think it's about 60 or 70% do have there's some semblance of a rudimentary horn. So they have a uterus, but it's on this other side, but it's not fully formed and it doesn't communicate. Okay, so you wouldn't see it on hysterosalpingogram, but you would see it on MRI, which is one of the reasons why MRI is a better way to go about than hysterosalpingogram. But I wanted you to see what this kind of looks like with HSG. All right, so the presentation will depend on whether or not there's a rudimentary horn. So when a woman or when an adolescent female has her period, she's going to need a way to get those menstrual contents out. Now the normal Müllerian duct, which communicates through the cervix into the vagina, will be able to expel its contents. The rudimentary horn, which does have endometrial tissue, will not be able to do that, and it will retain endometrial tissue, retain menstrual contents, and ultimately this is going to enlarge and cause pain. And so they will have secondary dysmenorrhea, which is going to be cyclical pelvic pain, which will start in adolescence. And so this is one of your differentials of secondary dysmenorrhea. In the absence of a rudimentary horn, then the most common way that this presents is recurrent miscarriage or preterm delivery. So you wouldn't have that secondary dysmenorrhea because you don't have a rudimentary horn. The only uterus you have can communicate, and so you won't have secondary dysmenorrhea. Now, if you have a rudimentary horn, you can have some major problems. So if a pregnancy implants in the rudimentary horn, and you might be wondering, how is that possible? You have no communication. How does the sperm get from the cervix to the rudimentary horn? It can actually get through via transperitoneal migration. So the sperm can get into that rudimentary horn that way, or you can have fertilization in the normal half of the uterus, and then the fertilized ovum can go into the rudimentary horn. So it is possible. If you implant into the rudimentary horn, 90% of these will rupture, and that can be fatal to mom. All right, so this is an indication for immediate removal of the rudimentary horn. This will present very much like an ectopic pregnancy. Okay, so this is an emergency, an obstetrical emergency. All right, so here's a unicornuate uterus with hysterosalpingogram, and then here it is with MRI. Okay, now the Didelphys uterus. Didelphys is Greek for twin, and that is exactly what we have. We have a twin uterus. So a Didelphys uterus is a complete failure of fusion of the two Müllerian ducts. So the Müllerian ducts don't fuse. They form properly, but they don't fuse. And so what you basically have are twin uteri. You have two uteruses. And that's going to be very apparent when you look on hysterosalpingogram or MRI. You'll see two uteruses, and they will typically form a single cervix. However, you'll often have a double vagina. So there'll be like a membrane separating in the middle of the vagina, and so this can be abnormal externally. Now, I'm not sure why you have, sometimes you'll have, you can have a double cervix, but not all the time. But you'll always have a double vagina. And I don't know why that is, because typically the way these structures come together is that they start to involute, they start to fuse caudally, and they work in a cranial direction. So the fusion goes caudally to cranially. So you would think that you should have fusion first in the vagina, then in the cervix, then in the uterus. But in fact, we have, in some cases, we have the cervix where it's fused properly, but the vagina hasn't and the uterus hasn't. I'm not sure why that is, but it is a classical finding for Didelphys uterus to have this double vagina. And we'll always have these two single-horned uteri as well. That's basically all you need to know about this. Now, the Didelphys uterus can look a lot like a septate uterus, and we'll talk about that in a little bit and how you can differentiate the two. But an MRI is going to be a good place to start. And the most common presentation here is recurrent preterm delivery. Why? Same reason for all these other uteri issues. It's that the uterus is just not big enough. And so you have a normal pregnancy, baby gets to be a certain size, it's going to stretch the uterus out to a certain point, and then you're going to have labor and ultimately delivery. The problem is the uterus is not big enough, and so it'll reach its sort of terminal size much earlier than if you were to have a normal size uterus. If that makes sense. So here again is a Didelphys uterus. This is much more apparent, but sometimes if these two horns of the uterus sort of come together, or these two uteri come together a lot closer, it can be difficult to distinguish this on hysterosalpingogram from a septate uterus and also from a bicornuate uterus, which is what we're going to talk about now. So you can see how it can be difficult, if these came together enough, it can be difficult to distinguish on hysterosalpingogram a Didelphys uterus from a bicornuate uterus. Now, a bicornuate uterus is a partial failure of fusion of the two Müllerian ducts. So you can have fusion at the top, the cranial part of the uterus, but not, at the caudal part of the uterus, but not at the cranial part of the uterus. Remember, it moves, the fusion will move cranially. It starts caudally and moves cranially. So the bicornuate uterus, you have two horns, but you can have, and you often do have, a single uterine cavity. Now this is going to look a lot different. So let's talk about why that is. Okay, so this can be complicated. So bicornuate uterus can itself be partial or complete. So a complete bicornuate uterus, you have two separate uterine cavities that are joined at the level of the cervix. So that's basically, if you were to look at you have the cervix and then two horns coming out. And that looks a lot like a Didelphys uterus. The difference here is that you don't have a double vagina. That is what separates a Didelphys uterus from a complete bicornuate uterus. It looks almost identical, but you don't have a double vagina. Okay, so very similar to Didelphys. A partial bicornuate uterus is where the fusion has made it a little bit further cranially. So you have one single uterine cavity, but then you have these two distinct uterine horns. This is the most common presentation for bicornuate uterus, and this is how it will classically show up on a test. So it doesn't fully fuse at the cranial portion. And so you have this separation. Now this is different from a septum. Okay, this is not a septum. This is true full separation of the two horns of these sides of the uterus. Not a septum. It's complete separation. If you were to look at this from the outside, you would see. So let's say you looked endoscopically, you would see two horns. And that's different from the septum. We'll look at that a little bit from the septate uterus. A bicornuate uterus is the most common uterine anomaly, about 45%, and the most common presentation is recurrent preterm delivery. Now, because a partial bicornuate uterus, you have a lot more room than these other ones we've been talking about so far. These ones will carry to term more frequently, and when they do, however, because of the size and because the uterus is so cramped, fetus might not be able to turn properly, and you can get malpresentation from that. So that's not uncommon. Okay, so this is a bicornuate uterus, but how can we tell if this is septum or if this is true separation of two separate uterine horns? We can't, and so an MRI is going to be helpful there. Now this is looking from the outside, so we're inside, but we're looking from the outside of the uterus, and you see that you have two horns. Here's a normal uterus, right? Okay, so here's our uterus, ovaries, fallopian tubes down here. So this is what a normal uterus looks like. It looks globular. Notice this, it's like heart-shaped, and that's because we have these two horns here. Okay. Now a septate uterus, where you just have a septum in the middle, it's just a problem with the inside of the uterus. So the uterus would look like this. That septum is on the inside. We'll talk about septate uterus now. So a septate uterus is a failure of the median septum to dissolve. So remember, what do we have? We have formation of the Müllerian ducts. Those two Müllerian ducts come together and fuse, and then you're left with a septum, which then has to dissolve, and that will also dissolve caudally to cranially. So if that septum fails to dissolve, you'll have a persistent membranous structure, which is the septum, separating the uterus at the midline. However, the external uterus will look totally normal because it's fused. The only problem is you have this septum in the middle, and you would not be able to tell that laparoscopically. You would only be able to tell that by MRI or hysterosalpingogram. So this only affects the uterus. There will always only be one cervix and one vagina. From the outside, as I mentioned, the uterus will appear completely normal. This is unlike uterine didelphys and bicornuate uterus, where you would see, if you were to do laparoscopy, you'd be able to see that you have two separate uteri, or you have two horns. A septate uterus may be partial or complete, and really that's pretty inconsequential. It just is saying how far the septum goes down. So a complete septate uterus will look a lot like didelphys if you were to do hysterosalpingogram, but like I said, if you were to do laparoscopy, you would see this is quite clearly a septate uterus because you have a normal appearing uterus. So you have two distinct uterine bodies, but one confluent uterus externally, and certainly you have one cervix and one vagina. A partial septate uterus is going to look kind of like bicornuate uterus. You have this horn, this septum that separates the normal uterine body into two horns. So if you were to do hysterosalpingogram, it would look like bicornuate uterus, and the reason is because you can't tell if it's a septum or if it's actually separate, if the two bodies are separate. Hopefully that makes sense. Go ahead and ask me a question if I haven't made this clear enough. The most common presentation, again, here is going to be recurrent preterm delivery. Malpresentation can happen as well. But as you're seeing, these are becoming less and less severe because the body of the uterus, the shared body of the uterus, is getting bigger as we go on. And that's going to culminate in our last one here, which is the arcuate uterus. There's really no good definition of arcuate uterus. Basically, an arcuate uterus, there's no uniform classification to distinguish it from a septate uterus or a partial septate uterus. Basically, the way we can, the way we differentiate arcuate uterus from a septate uterus is that with an arcuate uterus, there's no OB complications, which then leads you to wonder, why do we even make this diagnosis? No complications, no consequences. Some people think that an arcuate uterus is associated with a slight increase in preterm delivery, but there's disagreement upon that. The only thing you would notice, and typically this would be an incidental finding on MRI, would be this little concave septal dimple on the cranial aspect of the uterus, which represents just a small remnant of septum. So it's kind of on the continuum of septate uterus. So here's our Müllerian anomalies. We talked about all of these in detail except for the DES uterus. So this is a way you can distinguish these. Remember that the problems with formation of the Müllerian ducts are going to be much more severe in presentation. They'll present much earlier most of the time than the others. So agenesis can present, it will present with primary amenorrhea. They will not get their period because they don't have uterine tissue. Unicornuate uterus, you get secondary dysmenorrhea, typically from the rudimentary horn, but if you don't have a rudimentary horn, which is only a minority of cases, then it's going to be problems with obstetrical problems. Didelphys uterus, you can have one or two cervixes, that's important to remember, and you have the double vagina. Bicornuate uterus, you have the two distinct horns, and they're distinct, okay, which is different from the septate uterus, where you can have two distinct pseudo-horns, but they're really just the same uterus separated with a septum. All right, and then remember the arcuate uterus is asymptomatic. All right, so you can use this table to help you differentiate these out. Remember, the most common presentation is preterm delivery, so it should be on your differential for any patient who's had repeated history of preterm delivery. And that is all I've got for you.